I'm Paul Martin. I'm a family physician in Dayton, Ohio. I'm also the president-elect of the American College of Osteopathic Family Physicians, representing approximately 20,000 family physicians across the country. I'm also a member of a 55-member medical group. It's named Providence Medical Group, and we've just got into our electronic health record in July of 2011. So we've been on it for 8 months, so we're starting to experiment. We started out a little bit slow because it takes a little bit of time to adjust to the software. Once we adjusted to the software, now we're doing very, very well. We're having meetings every once in a while, and by that I mean about every 2 months or so, with our medical director, and we share our ideas as to what are the tricks, what are the shortcuts that we can find in our electronic health record so that we in fact can make it more efficient for the physicians that are using it and our staff, who is also inputting a lot of data before the physician walks into the office. When we first started to implement our electronic health record, we basically adjusted our schedules to about half time so that we in fact could learn the software. We did have some prep time that was for about 3 weeks before the actual implementation of the software. Once we had to start using it hands-on, that's when we took a little bit of time to let everybody get a chance to catch their breath, learn the software. Once they learned the software, then they could accelerate their use. Now, overall, I will tell everyone that's going to go into electronic health record that they will initially see this slowdown period. And even after they get on the electronic health record will in fact prompt them for a lot of questions and a lot of answers from the patients. For example, asking about the smoking cessation, asking about their weight and things like that. So these are things that maybe in the written record we didn't do, but we're doing now, which again takes a little bit more time. So I do want to caution to physicians that if they're used to seeing, as a family physician, 35 or 40 a day, they may only be seeing 30 a day, but they're doing and providing better quality medicine for their patients. And in the long run, will be better quality for the entire situation for the patient. As we go forward, what physicians will be seeing is probably the end of the fee-for-service payment program. We will probably be looking more at bundled payments and looking at more universal care of the patient. And that brings up the concept of the patient-centered medical home. The patient-centered medical home is going to be a home where the physician is the, as we can use the term, captain of the ship, and he's going to have all of the subsets that he needs within, or she needs within their practice to provide quality care for the patient. They may have a dietitian on board. They may have a chronic disease manager on board with them. They may not be there every day, but they could be shared between a number of practices. And what that patient-centered medical home will do will be that they become a better place for physicians to provide quality care for their patients. As we move forward, we will probably be looking into the accountable care organizations, which will be a joint partnership, sometimes with hospitals, and maybe a joint partnership with a number of specialists. And it will be an empowerment for the patients to actually provide for themselves a way to look into their electronic health record to find out what's going on with them, to review what the physician told them. After all, we as physicians tell the patients an awful lot in that 15 or 20 minutes when they're in the office with a primary care physician. Well, when we look at health IT and how it's going to interact with the patient and with the physician, we feel that it's going to have a very important role in that we're going to be able to provide quality registries for the physicians to look at and for the patients to look at, so that if there ever is a question that comes up and it approaches all of our diabetic patients, we can in fact go and query our database, provide that information to all those patients who are diabetic, for example, or hypertensive, or whatever the particular disease state is. In the past, we had to cull through all of our paper records, where with the electronic health record, we could put in the code 250.00 and bring up all the patients with uncomplicated diabetes, and then scan those patients for whatever information we want to provide for them, or cull them for information that the physician may need. When we're looking at the electronic health record, it's a very important decision for the physician. First of all, they've not seen great increases in their payment structure from Medicare and Medicaid over the years. So they want to find an area where they can go and that'll provide them the information that they need to look at the electronic health record. One of the areas that are provided right now for the physicians are the regional extension centers. Each of the states pretty much have a regional extension center, and the physician can contact the regional extension center for their state, and they can get good quality information as well as help for their practice. And that's personalized help for their practice to actually help choose an electronic health record and implement that electronic health record, with the hopes of providing themselves with stage 1 meaningful use so that they then can qualify for the dollars that the Medicare program will be providing in the future for them for stage 1, stage 2, and stage 3. With the Medicare program, the physicians are able to get as much as $44,000, and those physicians who take care of Medicaid can get as much as $63,000 to help offset the cost of implementation of a medical record within their office. For osteopathic physicians, we tend to have our physicians as family physicians. 40% of the American Osteopathic Association are family physicians. And most of our physicians, by and far, practice in communities of 30,000 or less. So there can be some challenges with just even the electronic data lines that we'll need to get into these smaller communities. So our physicians are going to have to be somewhat nimble with their feet as far as making sure that they can get electronically connected onto the different servers that they'll need to be. Some of the physicians may need to have their software right within their office as a server, or they may be able to still get on the internet and use an internet-based system. In respect to meaningful use, one of the most important things that I think for physicians today is they need to provide for themselves the electronic health record today. Get it started here in 2012 or 2013 so that they can qualify for meaningful use dollars in year 1, which is $18,000. That will help them offset the cost for that hardware and software that they're going to have to provide in their offices. If they do not provide this in the future, there will be penalties for those physicians who do not provide an electronic health record within their office. So we, in fact, need to encourage them. And as my role as president-elect for the American College of Osteopathic Physicians is to encourage our doctors to move from the 20th century into the 21st century.